Katie Harris, owner of Philly Wellness Center, and this is the Balanced Body Menopause Summit. And today we have Dr. Samantha Fazio Semar on with us. Sam graduated from Temple University with her doctorate in physical therapy in 2017, and she started the Pelvic Physical Therapy program where she specializes in pelvic floor health. And I'm really, really excited about this one because this is a big deal in menopause and for women really of all ages. So Sam, thanks so much for being here with us.
Thank you so much for having me. I'm really excited about this. This is like very important information. I'm excited to teach it.
Yeah, it really is. And, you know, I'm embarrassed to say, even as a nurse practitioner and a woman, I really knew very little about pelvic floor health. So I think this topic is so important for women.
Yeah, agreed. Yeah. All right, are we ready to get started?
Yeah, go for it.
Okay, great. I am calling this Pelvic Floor Health 101. Just as a sort of disclaimer, this is the very basics of information. There is so much more I could be diving into. I actually had like a big asterisk of stuff that I forgot to include in the slideshow. So if you ever have questions or there's something that you feel free. My contact information will be at the end of this presentation, but I just want you to sort of know that this is like the very basics, foundational information about pelvic floor health. So yeah, just a little bit about me. I went to Temple. I got my for my doctorate. I had a pelvic health certification in 2019. I personally have an orthopedic background. I do think that is very important. I'm a little bit biased about this. If you are searching for a pelvic floor physical therapist who has the knowledge of more than just the pelvic floor, I think it's very important that we don't narrow-mindedly look at the pelvis and we sort of are looking up and down the chain of the sort of human skeleton. So I just include that as like a little sort of asterisk if you're ever Googling pelvic floor PT near me or pelvic floor PT certifications, that is an important potentially thing that you want your PT or OT to be sort of well versed in is orthopedics in general and not just pelvic floor specialty. And then I founded Pelvio PT in 2021, essentially in response to the lack of care around pregnancy and postpartum in Philadelphia. I'm trying to revolutionize that as a standard of care. But today we're talking a little bit more about menopause. So I'm sort of gearing this presentation that way, but we will talk a little bit about pregnancy and stuff as well too. Okay, so I need to start with what first does a physical therapist do? I think there's a lot of people who have never even been to a physical therapist before, and I feel like it's very important to just talk about what is that specialty as opposed to a physician, nurse practitioner, things like that. So a physical therapist is a movement expert with a primary focus on rehabilitation. So our entire job is to look at the way your body moves, and then our goal is to improve your quality of life in terms of movement, typically after injury or onset of pain or some sort of dysfunction. Most often you see this in the sort of sports medicine world, in the joint replacement world, where you are, someone comes to PT for back pain or knee pain or post-knee replacement or post-rotator cuff repair, things like that. The PT's job is to prescribe exercise, hands-on care. We do a lot of patient education around modifications, ergonomics, things like that. We examine you, develop a treatment plan, and then ultimately, session by session and week by week, we're improving your ability to move, to manage pain, things like that. And it's all within the realm of wanting to restore. That might happen again. To restore function. So things like someone might come and say, I want to be able to walk 2 miles. I want to be able to sit and stand out of a chair. I want to be able to just climb up the stairs. Or it could be, I want to be able to run a half marathon. I want to be able to exercise. I want to be able to pick up my kids, my grandkids, things like that. And there has been a big move in the sort of recent years towards not only just rehabilitation, but also what we call prehab or prehabilitation, where we're trying to prevent future musculoskeletal dysfunction. So we're sort of moving to this sort of proactive training and proactive plan of care development. We're seeing that in the knee replacement world, in the ACL repair world, where you go to PT before the surgery, then you have the surgery, and then you do rehab after the surgery. And it's really improving outcomes in terms of like return to whatever sport or life or whatever. I am also in Pelvio trying to do the same thing with pregnancy. Let's prehab pregnancy. Let's prehab birth. So let's, start PT before the quote unquote injury happens. And so for our menopause audience, I feel that, or, people who are approaching menopause, let's do the same thing. Let's not wait until there's problems. Let's start to prevent these things. Let's take a look at what's going on. Let's try to be proactive in managing some of the stuff that's going on. So I think that's just an important conversation about how a PT in life can help you. Okay. And now what does a pelvic floor physical therapist do? So a pelvic floor physical therapist does all the same things that were on the previous slide, except as it relates, we try to improve the quality of life and movement as it relates to bowel, bladder, and sexual functioning. The bowel, bladder, and sex organs are housed within your pelvis. I have many slides on this we'll get to later. But there is a movement to these things. There's a neuromuscular component and there's a musculoskeletal component. So a physical therapist is really the one that should be treating some of these movement disorders. So we treat pelvic floor soft tissue injuries as it relates to child's birth, things like perineal tears, but also pelvic surgeries like hysterectomies. Prostatectomies is not necessarily the menopause crowd, but that's important for the older generations. We also help treat pelvic girdle pain. So things like hip pain, SI joint pain, any sort of lumbosacral pain that isn't necessarily responding to traditional orthopedic PT. And we do all of the same treatment techniques that I mentioned, exercise, hands-on therapy, with the exception that we have this internal component. So I'll explain that also in a little bit, but that is basically the nutshell, is that we just sort of dive a little bit deeper and we dive within the pelvis. And we are still physical therapists, and so our goals remain the same. We are most often referred to by physicians like gynecologists, urologists, and GI doctors, but you can also utilize your primary care physician, ortho specialist, hormone replacement therapist, or hormone replacement specialist. You can basically see any physician. It is also worth noting that in the state of Pennsylvania, many PTs have their what's called direct access license. And so we can see a patient, depending on your insurance, for 30 days without a script from your physician. But then after 30 days, we will have to get a script from your physician. So if you're ever considering seeing a pelvic floor PT, it is good to just get a script from your physician. Most physicians do not have a problem writing a script if they've been seen by you, if you've been seen by them. But that is just something sort of worth noting. Okay, let's get into it. What is the pelvic floor? All right, so I have my handy dandy pelvis here. That is very important because this is a 3D structure, so we need to be able to see this in 3D. So I have the pictures here, but let's look at it in 3D. So your pelvis is framed by, this is my mirror image here. Your pubic bone is right here in the front. We all know that bone that sits right at the front of at the base of our pelvis, right? You have your hip bones here. So if you were to place your hands on your hips squarely like that, that's where your hip bones are. You have your last two lumbar vertebrae of your spine here. And then if I turn this person around to face me, here's those last two lumbar vertebrae. And then you have your sacrum and your tailbone is this tiny little bone right here. Okay, so we have our bony framework of the pelvis. Now within that pelvis lays your rectum, this is that tube back there, your uterus, and your bladder. Okay, so they lay sort of front to back, corresponding to our holes. If you want to find your bladder, Find your pubic bone, your bladder's right behind that. A lot of people think it's very high in your belly, sort of near your belly button. That's not true. It's very, very low. It's sort of like right above your pubic bone there. So everything else is sort of encased in the bowl of your pelvis. If I take these organs out, you can see that your pelvis is literally a bowl, right? Everything you see in red is your pelvic floor. So your pelvic floor extends all the way out to your external genitalia. It is not this deep, elusive structure where you don't really know what it is. It is sitting there when you're standing, facing the ground. It's right there. This is the vulva, and essentially your pelvic floor is right behind the skin. That's it. It's right there. If you think about it, this person is now laying on their back, sort of spread eagle at you. You have your sit bones here. You have your tailbone is down here, and you have your pubic bone up at the top. So you have this sort of like diamond shape. Everything in between that, holding everything up, is your pelvic floor. You have your clitoris is in yellow, that little yellow dot. The little tiny hole here is your urethra. That hole is your vagina. And then here's your anus. And then everything on either side is the pelvic floor. And you can see it basically forms that like sort of bowl from the inside, corresponding to all of those holes I just mentioned. So the pelvic floor muscles is the group of muscles that lay at the bottom of the pelvis and form that hammock or bowl. And it reaches from the pubic bone to the tailbone and the sacrum and hip to hip. Now it consists of 3 layers. Not going to get into the weeds of what those layers are, but basically it has a superficial, middle, and a deep. I do want to point out that this is a presentation that I've used in the past that's not geared just towards the sort of vagina pelvises. So this, can you see my mouse here? This pelvis here is a penis pelvis. So that's why there's only 2 holes. There is a rectal hole and a urethral hole. So, and it looks a little bit more narrow, you can see, as opposed to the vagina pelvis, which is a little bit wider, sort of this way. And that has 3 holes, one for the vagina and the uterus. That's just, makes sense what you're looking at there. Okay. What does the pelvic floor do? So we like to call these the 5 S's. Let me make sure that gets away. Okay. 5 S's. Sphincter control, meaning it has to control peeing and pooping, meaning it has to be able to hold pee and poop in when you don't want to pee and poop, but then also let pee and poop out when you do want to pee and poop. There's a support function, meaning it has to lift and hold your organs up. There's a sump pump, we say. It helps with lymphatic drainage and blood flow. There's a sexual component where it controls arousal and orgasm, or at least assists in arousal and orgasm, and a stability component. So a lot of us sort of know that, understand outside the pelvis. If I take your pelvis back up here, from the back, you have your glutes on either side. You've got your piriformis muscles. You've got your abdominal muscles in the front. You've got your hamstrings, your quads, all these muscles that sort of frame the outside of your pelvis, and they help sort of stabilize your pelvis. Your pelvic floor provides the internal stability of that bony pelvis. So it's really, really important when it comes to things like walking, jumping, sitting and squatting, and sitting and standing, things like that. Other sort of secondary functions of the pelvic floor is that it aids and assists other musculature. So it assists your deep core musculature for spine stability and trunk control, but then it also aids in breathing. It coordinates with your respiratory diaphragm. I'm pretty sure I have pictures on this, but basically your pelvic floor does a lot more than just sort of hold your pee and poop in, which is kind of what it gets this rap for, is like we only really talk about your pelvic floor when it comes to things like incontinence or constipation, maybe, or even like maybe it's in the conversation about pain with sex, but really there's so much more that goes into the functioning of it. And I hopefully this sort of highlights this throughout the presentation, that there's a lot more things that your pelvic floor could be a missing sort of link to that you're experiencing, especially when it comes to menopause. But let's move sort of like above the pelvis for a second. So your pelvic floor and your core are basically one and the same. Your pelvic floor is part of your core. So a lot of people think that your core is just your belly muscles, just your abdominal muscles, and that is not true. I'm debunking that right now. Your core consists of 4 groups of muscles. You have your pelvic floor at the bottom of your pelvis. You have your abdominal muscles that extend up from your pelvis. You have your, if I turn this way, your back muscles that extend up your back. And then you have all your internal organs in here. They're not part of your core, they're just inside your core. And then you have your diaphragm. Your diaphragm is this muscle that up at the top that sits at the very bottom of your rib cage. I always like to think about your rib cage as like almost like a bird cage, right? And your diaphragm is the floor of the bird cage. But then your diaphragm also becomes the ceiling of the canister of your core. Does that make sense, right? We're looking at pelvic floor down here, diaphragm up here, back here, belly here, and if I rotate around, that's your core. So that's the sort of muscular framework. If we think about just your skeleton, you have your rib cage is up here, your pelvis is down here, you've got your arms coming off your rib cage, you've got your legs coming off your pelvis. The only thing sitting between those two things is your, like, quite frankly, measly little spine. And your core is what is designed to stabilize that tower of bones. If your core didn't exist, your spine would have so much load on it. So that's why your core is so important for spinal and trunk stability. And a lot of times why we, talk about if you're having back pain, you got to strengthen your core. That's why, if that helps make sense of things. But it's not just your belly, right? We have to be sort of talking about all 4 of those things together. I have another picture here. Now, again, I don't want to get too into the weeds, but just like sort of highlighting how all of these things are interconnected. The picture on the left is the layers of your abdominal muscles. So a lot of times you think about your abs as just these sort of 6-pack muscles, but you have layers of oblique muscles, layers of your what's called your transverse abdominis. Your transverse abdominis literally wraps around from your spine to your front, and it creates the canister sort of framework of your core. Excuse me. So we're not always just talking about your 6-pack muscles as the sort of the only thing that are important, which is why I hope we're sort of moving away from crunches as the only thing that is like good for your core, but there's a lot better, sort of exercises for those things. This middle picture highlights this person you're looking at their back. All of the muscles that go up and down your spine and attach from your rib cage to your hip bones, attach from your sort of hip bone there to your leg bone. Here's another picture. This one has your diaphragm in it. So your diaphragm is continuous with this muscle back here on your back and almost shares the same fascia with this is called your psoas right in here. So it's just to say that all of these things are connected. And if you're having something like back pain, but also maybe some stress incontinence or back pain and pain with sex, or back pain in the traditional, spinal area, lumbar spinal area, but then also maybe some butt pain, why it could be that your pelvic floor is really this sort of like missing piece of things. I hope that's a little bit more, understanding of those things. Okay. And here's my slide for it, is that when you have some sort of pelvic floor dysfunction, there's a lot of related diagnoses that can happen. Lumbopelvic pain, back pain, hip pain, pelvic pain. Also things like fibromyalgia, endometriosis. Those are things that don't exist within the pelvis, but because they are sort of these systemic issues or sort of above the pelvis or sort of around it, they can either contribute to pelvic floor dysfunction or cause pelvic floor dysfunction. So it's something that we could be looking at as it's like a which came first, the chicken or the egg. We don't know, but we can, if we're not looking at one of them, we're missing a piece of the puzzle. But also surgery. Surgery is a huge one, especially for the menopause population. We are a lot of times talking about people getting prolapse repair surgeries, things with like mesh. Prostatectomy is not obviously with the menopause population, but prostate cancer is a huge topic of conversation within the older generation, at least. So it's worth putting in here. Pregnancy, think about the canister. During those 9 months, your canister is growing bigger and bigger and bigger and in a pressurized system. And I always say it's like trying to fit 10 pounds of potatoes in a 5-pound bag. I had to think about that for a second. But it's very tight and there's a huge load and it's, right. So can you imagine how that really messes with your canister? Significant increase in intra-abdominal pressure, especially on your pelvic floor. Then also things like pelvic injury, muscle tearing. A perineal tear is a muscle tear. So if you had a perineal tear in childbirth, even if you had a cesarean birth, if you have any sort of pelvic injury, pelvic ligament injury, that can lead to range of motion loss, scarring, impacts the entire core system. And then this last one's very important: chronic stress and chronic pain. That's sort of where this fibromyalgia group comes in as well, an endo group, but even just sort of the menopausal group, this can happen, especially with stress. Everyone's stressed nowadays. The pandemic really did a number on us, I think. Your pelvic floor is highly regulated by your nervous system. That is why the term anal retentive exists. Tight ass, excuse my French, tight ass, right? Tight butthole. Those are things we say. Because when we get stressed, anxious, nervous, or we're in a ton of pain, we're very upregulated, we clench our sphincters. And many times a chronically clenched sphincter or chronically clenched pelvic floor can lead to issues. Imagine if you're like this all day. Many people who are stressed have sort of high shoulders, clenched jaws. Then that leads to TMJ issues, neck pain. If you are clenched in your pelvic floor, that can lead to a whole host of problems that you're not even really considering, right? We don't necessarily think about it the same way, but it's the same thing as holding stress in your shoulders and holding stress in your jaw. Okay. Now we have to talk about Kegels. Like number one thing that people, when I tell people I'm a pelvic floor physical therapist, they say, oh, the next thing isn't mentioning of the Kegels. You Google pelvic floor and it's the number one word that comes up is Kegels. A Kegel is named after the doctor who first studied how to utilize pelvic floor muscle functioning to treat incontinence. So his name was Dr. Kegel. That's why he named these after himself. But basically, a Kegel is a pelvic floor muscle contraction and subsequent relaxation. It is very much like a bicep curl for your pelvic floor. You are contracting the muscle and relaxing the muscle. Now, I highlighted the subsequent relaxation because many people think it's just the contraction. And so a lot of people do their Kegels and they kind of just go contract, 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 contract. And that would be like doing a bicep curl like this, right? You have to think about the full range of motion. You have to be going all the way up, all the way down, all the way up, all the way down. If you can't go all the way up, that's a problem. And if you can't go all the way down, that's a problem. So I always sort of use the biceps as an analogy here, but your biceps is actually just a longitudinal muscle. It works in one direction. So I like to think about your pelvic floor as more of a trampoline. Your pelvis would be like the ring around the trampoline, and the pelvic floor muscles are like the mesh that you jump on. Now that at baseline, there needs to be sort of this buoyancy, what we call tone. It needs to just sort of have like a good sort of quality bounce to it. We don't want it to be too taut to the point where it can't do anything, but then we also don't want it to be like one of those trapeze hammocks, the trapeze artists, they don't bounce back, they just sink into the net. We don't want it to have no bounce back. So that's sort of the way we think about it, is it has to be able to go up, it has to be able to come down, but we want it to have this sort of nice, healthy buoyancy to it. And for that reason, we want it to be both under voluntary control. You have to be able to contract and relax it on your own with your brain. But then we also want it to be under involuntary control, like when you're standing up and sitting down from a chair, when you're jumping, when you're running. You don't have to be thinking about it. We want it to be happening on its own. We also want it to be able to relax on its own. When you sit down on the toilet, you tell it to relax. I'm peeing now. And then when you stop peeing, I'm done peeing. And you need to be able to hold that in, right? So that's what I mean by voluntary and involuntary activation is required. Okay. This is another slide that is very, very basic. It's so much more in depth than this, but this is important to note kind of where we umbrella term things. How we denote pelvic floor dysfunction is by saying you can either have an underactive pelvic floor, an overactive pelvic floor, or a non-functioning pelvic floor. That's very, very basic, but it helps, I think, just frame some things. An underactive pelvic floor would be that sort of like can't contract, does too much relaxing. We tend to see that with things like prolapse, incontinence, and erectile dysfunction. An overactive pelvic floor would be one that's too taut and isn't bouncing at all and isn't relaxing. We tend to see that with pain with penetration, pain with erection, voiding issues, urinary retention, where you can't sort of relax those muscles, constipation, urgency, overactive bladder, pudendal neuralgia, and pelvic and low back pain. The thing that is important to note, though, is you can also see overactivity in prolapses and in incontinence. So that's just like a big piece of information. Just because you're experiencing incontinence or just because you're experiencing a prolapse does not necessarily mean that you have an underactive pelvic floor. You could have an overactive pelvic floor. This is why you probably should see a pelvic floor PT if you're experiencing these things, because it's a little bit more complicated than that, but we tend to sort of just frame these things this way. And then non-functioning pelvic floor would be nothing's happening and we need to figure out why. And it can cause any of the above listed. Okay, so let's move now into sort of how these things work with your bladder. I think I actually took the bowel section out of this slide, or out of these slides. We can talk about bowels another day, but I feel like the bladder is, very important for especially this population. So how your bladder works essentially is your bladder is, so this is your bladder. It's like a balloon. This is your pelvic floor, sort of that bowl we're looking at there. That's why it's shaped like that. Your bladder is, let's say, empty. Over time, and your pelvic floor muscle is contracted. Over time, your bladder starts to fill with urine and the balloon starts to stretch a little bit. Your urethra muscle remains contracted. Then when the bladder is fully filled with urine and that muscle is very stretched, it's time to go to the bathroom. What happens is you go to the bathroom, you sit down on the toilet, your pelvic floor muscle, that urethra muscle, relaxes to let urine out, but also your bladder muscle contracts to help push it down. I mention that because a lot of people think that you should be pushing your pee out. You should not be pushing your pee out. Your bladder pushes your pee out. If you are someone who pushes your pee out, you should be seeing a pelvic floor PT. Big effort. If you cannot relax this muscle, though, your bladder will have a harder time pushing your pee out, which could lead to things like voiding dysfunction, trickling, things like that. So basically, once the bladder is fully empty, now the bladder is deflated again, pelvic floor contracts to stop the flow of urine, the bladder muscle sort of relaxes to be inflated again. This is a learned behavior. Let's go all the way back to when we're infants, those of us that have kids, grandkids. We do not know how to do this inherently, right? At least the voluntary control piece of this. Your bladder fills, it sends a signal to your brain saying it's time to go to the bathroom. Our brain relaxes our pelvic floor, bladder contracts. It's all happening without our conscious effort. When we're potty trained, we learn to control that behavior. So for that reason, it is highly subjected to conditioning, Pavlov's science, things like that, right? So If you are someone who does what we call a just in case pee, a jick pee, where you go to the bathroom sort of all the time, so you don't, maybe you won't, you're afraid you will have to go later, or you go before you leave the house because you don't know if there's going to be a bathroom there. What you're doing is sort of infiltrating this system and teaching your bladder it gets emptied at a quarter filled or half filled. So then the signal starts to be learned. I have to go when I'm a quarter filled, half filled, or whatever. This is where overactivity and frequency comes from, many times, not the only thing, but many times, to where you've trained your bladder to give you the signal before it's actually full. So that is something that we can do in pelvic floor PT, is sort of essentially re-potty train you, redo the cycle, relearn these behaviors, refamiliarize yourself with what a full bladder actually feels like, and make sure your pelvic floor can withstand the pressure of a full bladder, right? That's very important, that this is a learned behavior, and so you can maltrain it. So a lot of times that's what's going on. There are some other things that are happening, especially in the menopause generation, with urethral hypermobility. Maybe that muscle can't contract as well to hold things back. So that's why it feels like you have to pee all the time. There are things like, it's just weak, and so that's why it feels like you have to pee all the time. So at a certain point, maybe the bladder's only half full, but your urethra is like, I can't hold it anymore. So there are some more other things that go into overactivity and frequency, but many times it's simply just a sort of a learned behavior of you simply just did too many jick peas over your lifetime. So what are normal bladder functions? You really should be voiding your bladder about 8 times a day. More than that, that's the problem. It should look about every 3 to 4 hours. If you're someone that goes every hour, that's kind of a problem. I always like to say, and a lot of people will notice this, like if you're sitting at dinner with a group of friends your age, are you the only one that's getting up to go to the bathroom? Are you getting up the most frequently? Like that could be a good signal, like, oh, maybe I have a problem here, right? And then we should really not be voiding at night. 0 to 1 voids at night after bedtime. If you are regularly getting up 1 time to pee at night, maybe worth considering, especially if your daytime is also interrupted. But if you're getting up 2, 3, 4 times a night, not good, right? And we need sleep, especially as we get older. You need sleep to be restorative and regenerative. And if it's being interrupted by peeing, not good. So the first sensation of urgency comes at half full, but you should just sort of be aware of that sensation. You do not need to go there. Many times people are like, I kind of have to pee, let me go. Well, no, that's not a full bladder, right? I always like to think like how growing up, my dad used to say, you don't run the dishwasher when it's half full, right? So you don't necessarily have to go just because you feel that urgency. You should be able to wait at least another 2 hours if there's no infection. That is also important. If it feels sudden onset and all of a sudden you're peeing all the time, call your doctor if there could be a potential infection present and we want to nip that in the bud, right? But if this is something that's sort of been going on for a long time, you've had negative testing and things like that, really we should be looking at why you're going so often. Also, your H2O, your water intake, should be normal. I'm going to talk about that in a second. An average void time, meaning when you sit down on the toilet to when the flow of urine starts to when it stops, should be about 8 to 15 seconds. If you are peeing shorter than that, it's probably not a full bladder. And if you're peeing way longer than that, it could be because it's trickling. It could be because it's trickling and it's taking too long. Maybe something's happening with your urethra, it's not letting it out. Or it could be because you're waiting too long, right? We could be into that world where now your bladder muscle is so overstretched, it's having a hard time sort of like getting it out. The general recommendation, this is big, general recommendation for drinking water is to drink half your body weight in ounces per day. So if you weigh 120 pounds, the general recommendation is about 60 ounces of water. That It changes if you are someone who regularly exercises and sweats a lot. That changes if you are pregnant. That changes if you are on certain medications. That changes if you have kidney disease. That changes for a lot of things. So be sure that you're sort of talking to a health professional about it. But if you need a place to start, that's a good place to start. You should be drinking water throughout your day. I once had a patient who said to me that she drinks all of her 80 ounces in the morning. So she checks that off her list, and she's got her water intake for the day. But then she was having all these frequency issues because she was overloading her body, overloading her kidneys with water, like, front loading. That would be like saying, I like to eat 2,000 calories in a day. I'm going to eat all my 2,000 calories for breakfast, and then expecting that you won't be hungry later. That's not how it works, right? You will digest all of those calories and you'll still be hungry later. You're going to intake all that water. You're still going to be thirsty later, and your body still needs water. So really, you should be drinking this water throughout your day. And you should be sort of looking at what we call bladder irritants. Bladder irritants are things, all the good stuff. It's things like coffee, alcohol, carbonated drinks, acidic foods, spicy foods, citrusy foods, and chocolate is a bladder irritant because who knows why. It's something about the way our kidneys digest it or something like that. That I am actually not sure about. I just know chocolate is a bladder irritant. These things can increase frequency. It's why when we drink alcohol, we have to pee more often. It literally can irritate the lining of our bladder and make us have to pee more. That is not to say that you can't have a glass of wine. That's not to say that you can't have a cup of coffee or tea. Tea is another one. People think tea is a good one, but it's not always. You just have to be paying attention to how much of that thing you're drinking. Are you supplementing your water intake with seltzer water and all you're drinking is seltzer water, and it's contributing, you're having a frequency issue? That's important to look at, right? Carbonated beverages can irritate your bladder and increase frequency. That's something important to note. And we want to, maybe just switch to water for your source of hydration. Okay. This is also a very important notice I'm going to highlight here. Drinking less water does not reduce frequency. This seems very counterintuitive, but dehydration actually concentrates your urine, right? And we've all been there where we've been really dehydrated. Our urine gets more yellow, gets more like sometimes even brown. Concentrated urine is also a bladder irritant. So it can also increase urgency. I've had so many patients, especially in the menopausal and postmenopausal generations, where they come in and they say, I really don't drink that much water. I don't understand why I'm peeing that much. Well, that's probably why. We need to dilute your urine and make it nice, the urine that your bladder wants to hold on to it longer. Your bladder is a storage organ, and it should be storing your urine effectively. And if it's irritating it wants to get rid of it quicker. So drinking less water does not reduce frequency. If that is you should stop and start with that general recommendation. Talk to your doctor about it. But that is huge, especially for this population. Okay. Yeah, I did take out the bowel. We can talk about bowels another time. I could talk forever about pooping. Okay. I do want to talk about stress incontinence because this is a huge thing, honestly, for women everywhere. Your organs sit on top of your bladder. Okay, so I'm going to take your bladder and your uterus. Here's your uterus, here's your bladder. All right, so this person is facing, actually, let me do it the same way. I think, is that facing the same way as the slide right now? Bladder, uterus. Oh no, I have to do it this way, mirror it this way. Okay, so here's your bladder. This is right here, that's the bladder. So we're looking at the side of it. Here's your vagina. This is the tube of your vagina. And then here's your uterus that sits on top. So that's the tube of your vagina. Your uterus sits on top. Okay. In this bottom two pictures, you can see this is a full bladder, and see how it sort of pushes the uterus sort of up and out of the way. This is an empty bladder where your uterus sort of comes down on top of it. I think that's an important thing to note. Number one, for people who have been pregnant, Your baby literally grows on top of your bladder, hence why you have to pee so much in pregnancy. Frequency in pregnancy is very normal. It's simply a space issue. There's not enough space for your balloon to fill to the way it could. And so when you're pregnant and you're having frequency issues, sometimes it's like, it is just going to be the way that it is until you don't have a baby. What we don't want when you're pregnant, though, is leakage. So if you're having frequency issues when you're pregnant, it's like, okay, we're just going to deal with this later. But are you frequently peeing, but also leaking? We need to talk about that, because your urethral muscle should still be able to withstand the additional pressure. Okay. A fuller bladder requires more closure support at your urethra because there's more pressure inside the balloon. But also increased pressure from above requires more urethral closure. So things like coughing, sneezing, laughing, jumping, lifting. Imagine how all of the organs, you have more organs that sit above this. You have all your intestines, you've got your stomach and your liver up here. All of those organs slam down on your bladder when you're coughing, sneezing, laughing, jumping, lifting. Your urethra needs to be able to withstand all of that pressure and needs to be able to sort of meet the pressure. So every time you jump, there's an increase in closure and then it kind of releases, increase in closure and kind of releases. If the closure support is not able to withstand the pressure, you will be leaking. And that's what stress incontinence is the inability of your urethra to maintain urine when under stress. Closure support can decline with pregnancy, but also age, hormone-related changes. So that muscle can be affected if you've never had a child, but all of a sudden you're leaking. It can be affected by a lot of other things more than just pregnancy or childbirth. And age is a huge one because our tissues tend to get a little bit more atrophied, a little bit thinner. And so that muscle function tends to not be as great, but also hormone related changes. So sometimes we're seeing this with people who have been on birth control for a long time, or even just sort of like had a little bit of excess weight, or people who all of a sudden started lifting heavy, CrossFit, and people are getting as huge, people are getting into the gym, people started working out more with the pandemic. That's fantastic. But then they started lifting heavier weights that maybe their body wasn't ready for. So those are sort of like some things to watch out for. But that's what stress incontinence is. And it is many times an issue of that urethral muscle. And why is it not doing its job? And a pelvic floor PT can help you figure that out. All right, I do want to talk about sexual function as well, kind of really quickly. But basically what happens when it comes to your pelvic floor is that your pelvic floor muscles are designed to contract and relax, just in general. That's not the way they work. But they actually relax to allow blood flow to our erectile tissues. So they help engorge the tissue with blood. And then an orgasm is actually the kind of rhythmic contraction and relaxation of the muscles, and it helps pump blood flow back out of the area. So if you are having pain with sex, decreased arousal, but also decreased orgasm ability, it could be a cause of a pelvic floor impairment. It also could be related to a lot of other things, but if you've sort of done the testing with your physician and you've looked at muscle tissue and lubrication, and there's mental arousal is a huge thing, especially for the female population. So if you've spoken to a mental health therapist and things like that, then the pelvic floor is a huge sort of piece of that puzzle that could be contributing to some of these things here. Okay, last but not least, this is sort of my conclusion. Misconceptions that we say, just do your Kegels. No. Kegels can sometimes be detrimental if you have an overactive pelvic floor. So if you have something like pain, incontinence, anything like that, Kegels are not always the answer. The answer should really be go see a pelvic floor physical therapist. Hover over the toilet seat when you're peeing for hygiene. No, do not do this. Never. The pelvic floor cannot relax this way. When you're in a squat, you're holding a squat. This position, your core, think about your core. It's all like, it's holding you up. It's very tight. And so you're going to try to pee through a tight hole that will never work. But also, if you do that repeatedly, you're teaching your pelvic floor to relax when you're in a squat position, making it more likely that when you squat to pick up a laundry basket or your child, you will leak in the future. So we do not want that. Just put toilet paper down. Also, that's been debunked a lot, that the toilet seat is actually not as dirty as we think it is. So just sit down. You'll shower later. That's my motto. Always pee before you leave the house, just in case. No, this can create bad bladder habits. Do you have to pee? That's important. Do you actually have to pee? If you're going on a 2-hour long car ride and you really don't want to stop, okay, fine, you can pee, but don't make it a regular habit, right? That's the thing that we don't want. Leakage is normal. No, 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 no. You see that in the commercials for like Poise, these Thinx underwear where they say, like, you've had a kid now, you leak. No, it ain't normal. Leakage of any kind is never normal. It is common, but not normal. And it can be treated with pelvic floor PT. Sex is a little uncomfortable. It's no big deal. No, all parts of sex should be pleasurable. All parts, meaning foreplay, external stimulation, arousal, penetration, orgasm. If any of those things are painful, no. This isn't a big one. My doctor told me to just use lube. I said, what do they know? I'm just kidding. They know a lot. They do know a lot. But your doctor is really, most of your physician is many times just checking the quality of your tissue, looking at hormones and things like that. And so if they say just use lube, they're saying it's because your tissues are okay, right? But if you're still having pain, did they check for proper flexibility and range of motion of these muscles? You need to be able to, if we're talking about penetration, those muscles need to be able to stretch to allow something in. If it's not allowing stretch, that could be a huge piece of this puzzle. So lube can help, but many times people are like, I've tried lube, right? And it still hurts. So that's not to say lube can't help. It's not to say your doctor doesn't know what they're talking about. Your doctors all know what they're talking about, but they are not always looking at your pelvic floor the way that we are with the same lens. And that's a huge, huge piece of information. Okay. This is the last sort of final, last little list here, just like an all-encompassing list. If you have any of these things, or you've been told by a physician you have any of these things, a pelvic floor PT can help you, can help solve some of these problems. I kept all the prostatectomy, prostatitis, testicular pain stuff on here because even though that we're talking about menopause, and that's geared towards the female population, a lot of times people have partners with these things that they're not getting checked out. Prostate cancer is, I believe, the leading cancer in men over the age of 75. And the statistics of men over the age of 75 who will get prostate cancer are very, very high. So that's very important that pelvic floor PT can help manage these things. We can treat the certain diagnoses, but there are some that we can't treat in terms of curing, right? And that's that last little list here. Pelvic floor PT will not cure endo, ulcerative colitis, Crohn's, IC, or IBS, but we can help manage the symptoms of it. So that's an important qualifier there as well. And then here is the contact information for Pelvio Physical Therapy, just sort of like a shameless plug here. We do not work with Medicare. I know we were talking to the menopause population here. We do not work with Medicare. We would be completely out of pocket at Pelvio for the Medicare population. So that is just an important thing that I would like to say. But there are plenty of pelvic floor PTs who do work with Medicare. And if you ever need help finding one, or if you want to do some telehealth or things like that, and do out of pocket or whatever, we can do some wellness sessions for our Medicare population. But if you are not yet on Medicare and experiencing menopausal symptoms or experience any of the symptoms that I've talked about, we'd love to see you at Pelvio. We're in Northern Liberties now, but we also come to your home. Just a little plug there.
I love it. Sam, this is amazing. And you said so many things that just kind of clicked for me. One, the whole don't wait for problems, because I feel like that's how we've been trained in allopathic medicine. It's kind of like you have to wait until you have a diagnosis and then we can treat you. And it's like, this stuff has been brewing sometimes for years or decades, before people actually get help. And by then it makes it so much more complicated. Like, just get it fixed, work with it now.
And especially if you are going to have children or you've had children, it's almost guaranteed something will be wrong eventually, right? It's like expecting to run marathons your entire life and not expect that probably by the age of 60 your knees will hurt, right? That's like, of course they're gonna hurt, but there's things we can do about it. It doesn't have to be that way. Also, though, this is important, insurance doesn't always love to pay for preventative medicine. Many times Medicare is one of those things, and Medicare likes to see progress. And so if you are doing maintenance physical therapy, they don't love that. So that is also an important piece of this, is that as a society, we haven't really moved towards preventative care because insurance doesn't always pay for that. And it's just an unfortunate reality of our healthcare landscape that, we have to pay out of pocket for sometimes it's some of these services, but we really do try to get these covered by insurance because we think it's so important. And if something is going wrong, say something, and that's your diagnosis. That is, stress incontinence is a diagnosis to put into your insurance. That works, that's just an important sort of like reality of where we are.
Yeah. And I think people, especially after the pandemic, are really coming to that conclusion as well, is that, I'm not quite sure that the insurance companies have our best health interest in mind. So a lot of people are going outside of insurance to get the help that they need, knowing that waiting for a diagnosis is sometimes just too late. It's kind of like what we have with weight loss. You have to wait until you're a BMI of 30 with like 10 diseases. And it's just kind of like, well, why? We could have headed this off like a decade ago,
Totally.
We could have prevented the whole thing from happening in the first place.
Save so much money. Yeah.
Yeah. It's like that short-term investment saves so much more money in the long run.
Right.
And then, I loved what you said about, the woman who drank all her water in the morning. It's like women love to be so efficient and we're so good at it. I was really laughing when you talked about that. And as a nurse, like I really, I tried to avoid as much as possible going to the bathroom because it was, we're always so busy and running around and stuff. So, I've got a lot of issues to deal with that, catch up with you 20 years later for sure.
Yeah. We call that the nurse's bladder, the teacher's bladder, where sometimes you almost wear it as like a badge of honor. Like I could go 8 hours without peeing, but then it's like, oh, that's good.
Well, yeah. So congratulations. And now you're at pelvic physical therapy. Right. But yeah, you gave so much great information for women, and a lot of this stuff I don't think is obvious. People don't associate hip pain, back pain with a pelvic floor, and the model that you had was absolutely phenomenal because it gave us a real visual of what we're working with. That muscle is huge.
Huge. It's everything. Yeah.
Yeah. So it's good to know that there's something that can be done about it and they can come see you, and I love it. So thank you so much for sharing this with us today.
Of course. Thank you so much for having me.
Absolutely. All right, everybody. If you need physical therapy, and after this talk, I know probably the majority of us need to call you. You can all see something of ourselves in here, but yep, absolutely. Just give Dr. Semar, give her a call at Pelvio Physical Therapy. All right.